Hello, everyone. Thank you for the opportunity to present today. This project is funded by a grant from SAGES awarded to Dr. Fiore and Dr. Feldman. Otherwise, I have no conflicts of interest to declare. So North America is currently facing a crisis of opioid addiction and overdose that kills on average 54,000 people every year. There's a growing amount of attention being paid to the widespread practice of prescribing opioids for post-op pain management, as 6 to 17% of patients become persistent opioid users after surgery. Additionally, 40 to 70% of opioid pills prescribed for surgical patients go unused. This is relevant as these unused pills often become a source of opioid diversion for non-medical use by others. One answer to the opioid crisis may be prescribing only non-opioid analgesics after discharge, which is common outside of North America. However, the value of this approach should be assessed in randomized control trials. Undertaking an RCT involving OFA raises some concerns, including surgeon and patient hesitancy towards post-op recovery without opioids. So due to the inherent complexities of well-designed RCTs, we recently completed a pilot trial to assess for feasibility of conducting a full-scale RCT. The pilot study was presented at the last SAGES meeting, and it's currently under review for publication. This was a pragmatic parallel two-group assessor blind pilot RCT, where we recruited 80 adults who underwent outpatient procedures in general abdominal and breast surgery at 2 hospitals in Montreal, Canada. Patients were randomized to receive either opioid or opioid-free analgesia after discharge. As OFA was new to our institution, a study hotline was available for patients in the OFA group. And so when this line was called, patients were informed about a backup opioid prescription that was faxed to their pharmacy on the day of their discharge. We assessed 224 patients, 81 were randomized, 39 received opioids, and 37 received OFA. Results show that all the feasibility criteria were achieved, including the rates of eligibility, consent to randomization, and complete follow-up. Pain outcomes, such as pain intensity and interference, were comparable between groups, and only one patient in the OFA group received the backup opioid prescription. Meanwhile, rates of adverse events, postoperative complications, and unplanned hospital visits tended to be higher in the opioid group. So while this pilot trial provided important quantitative data to inform the design of larger trials, the incorporation of qualitative methods can also contribute relevant information regarding participants' perceptions about the trial methods and interventions. Currently, little is known about patients' and clinicians' views regarding OFA and their acceptance of the trial procedures. So the aim of this qualitative study was to explore patients' and clinicians' perspectives and experiences while engaging in the pilot RCT. This was a qualitative description study where patients who participated in the recruitment process, including those who did not consent to the trial, were invited to be interviewed. We also invited perioperative care clinicians, such as nurses, anesthesiologists, and surgeons, who were involved in the care of patients in the pilot trial. We aimed to recruit a minimum of 10 participants. However, interviews were conducted until thematic saturation was reached, and this is the point when no new concepts or themes were identified. We used quota sampling method to ensure the recruitment of patients and clinicians with diverse characteristics. One-on-one semi-structured interviews were conducted to gain a deep understanding of participants' personal views. All interviews were audio recorded and transcribed verbatim, and data was analyzed using an inductive thematic analysis approach. The thematic analysis approach is a qualitative method that proceeds in several steps, involving multiple rounds of iterative comparison between the codes and the derived subthemes and themes. So in the end, this process gives rise to a final thematic map that gives us a rich description of the qualitative data. Thematic saturation was reached after 20 interviews. We interviewed 10 patients, of which 6 were female and 8 were involved in the pilot trial. And there was also an equal distribution of patients undergoing abdominal and breast surgeries. We also interviewed 6 surgeons, 2 anesthesiologists, and 2 nurses. Out of the 6 surgeons, 4 were specialized in general abdominal surgeries and 2 in breast surgeries. Analysis of the interviews revealed 5 overarching themes. The first theme is readiness for trial engagement, where we identified factors that motivated patients and clinicians to engage in the pilot trial. Participants recognized the importance of the research topic given the current opioid crisis and supported the need to reduce opioid overprescribing after surgery. Patients who declined participation in the trial revealed concerns about inadequate pain control using only OFA. Pre-trial thoughts about the interventions was another major theme. Many patients indicated having a preference for relying less on medications, especially opioids, for post-op pain management. Likewise, clinicians stated their concerns about the safety of opioids given the risk of addiction and other side effects such as constipation and nausea. On the other hand, some participants expressed doubts regarding the effectiveness of OFA and stated that opioids may benefit a subset of patients who experience breakthrough pain. Other concerns were about the side effects of non-opioid drugs, such as NSAIDs, increasing the risk of bleeding and acute kidney injury. Another important theme was post-op pain experiences, where patients in both groups reported experiencing minimal to considerable pain after their surgery. So for example, one patient said their pain was more like a bruise or an ache, whereas others reported considerable pain that interfered with their daily routine. However, most of these patients described their pain subsiding within 1 week and felt no need to take additional medications for pain. This next theme is about the acceptability of the trial and interventions. Experiences with the pilot trial were positive. Clinicians praised the study design and organization, and patients perceived the follow-up questions relating to pain, physical and mental health to be thorough and relevant to their recovery. Most surgeons stated that having the backup opioid prescription was reassuring and appreciated that opioids were available if patients' pain was not well controlled. The last major theme was trial refinement. Suggestions given included optimizing post-op pain management by setting patient expectations and emphasizing the use of non-pharmacological strategies to relieve pain. Other feedback included reducing patient burden by decreasing post-op questionnaires and preventing potential bias arising from the inconsistent use of peripheral nerve blocks in the OR. So in summary, though opioids remain the standard of care treatment for post-op pain in North America, alternative strategies should not be overlooked. Findings from our feasibility studies support the conduct of a full-scale RCT to compare the effectiveness of opioid versus opioid-free analgesia after outpatient general surgery. Lessons learned from this qualitative work will inform the design of future trials that will contribute to evidence-based prescribing. Thank you, and I'm happy to take any questions from the audience.